Good afternoon. If you keep that up for another 2 hours, we can just go home. Well, my name is Freddie Weinstein, and I'm the medical director of Dominican Hospital Behavioral Health Unit. Hearing okay? Okay. And one of the goals of the conference over the years has been to not only sort of provide a keynote speaker to bring us information from a statewide or nationwide viewpoint, but also to counterbalance that with some local information. And this year is no different. And to help bring the topic back home, we've assembled a crew here of professionals ranging from law enforcement to UC Santa Cruz to Santa Cruz County Mental Health Services. And in this part of the presentation, I will introduce each of our panel members. They will then in turn give a brief explanation of their job, their duties, and the impact that methamphetamine abuse has had in their area of the world. And then I've collected here from you guys various questions that I will direct to whatever panel members would be appropriate to answer them. And we'll see how it goes from there. So I will start by introducing Dr. Terry Lapid. Dr. Lapid is Medical Director of Dominican Hospital's Emergency Services. His undergraduate degree in psychology is from the University of California, Berkeley, and he received his medical degree from the Universidad Autónoma de Guadalajara. That's a mouthful. His residency in emergency medicine was at Kern County Medical Center in Bakersfield, and he is board certified in emergency medicine, and he's been with us at Dominican Hospital since 1982. So, Dr. Lapid.
Thank you. Thank you very much. When we were preparing for this, we wanted to sort of give a flavor of how methamphetamine affects our community and each one of our lives. And I think one of the things that we see with methamphetamine use in our community and that we don't quite know how to put into the formula is the effects that it has not only on the individual but on the rest of the community. And I think you're going to hear some interesting points today, but currently right now approximately 30% of the patients with drug testing in our facility do test positive for methamphetamine, which is a really high number. Now, once again, we're not doing drug testing on everyone who comes in, so we don't know the effects and how many other people may be affected by this. And in the emergency department, what we see particularly are the initial effects of truly the combative psychotic patient, which apart from taking care of the patient, when we try to look at how that affects the department or how it affects the staff, is you're putting staff at risk for having to subdue these patients, you're putting them at risk for injury, you're putting them at risk for exposure, as well as the law enforcement and pre-hospital people who are doing that. And that does not get factored in very well as just the time constraint and the energy and resource utilization of a combative, flailing, obstinate patient certainly gets everyone's attention much more than when you come into the emergency room with a sniffle or a cold. So it does tend to disrupt things and obviously change the dynamic. We'll probably talk a little bit more truly about some of the other issues, but one of the other things that we find in Santa Cruz County, once again anecdotal, is we have a number of nurses who come and work in our emergency department who are known as travelers. In other words, come from other areas. And I think a universal comment from those nurses, and they're coming from all over the United States, is they're quite impressed with the high number of drug and alcohol visits that we have in our community. So it is an issue. And it does have its ramifications throughout everything. So I think one of the things that I think today we're going to try to do is get some of that information out to you.
Very good. Next on our panel is Dr. Bill Manov. He has been the director of Santa Cruz County Alcohol and Drug Treatment Program since 1988. His duties include the responsibility for all aspects of publicly funded alcohol and drug prevention, intervention, and treatment services, with a program having an annual budget of $7.2 million and a staff of 23. Areas of responsibility include planning, program development, management of service subcontracts, program evaluation, budget management, fund development, and liaison with community groups and advisory boards. So he's quite a busy man. Mr. Manov.
Thank you very much. Well, I'm seeing a lot of the usual suspects out here, people I work with every day. And I'm also seeing a lot of people that I don't know. And I think that's excellent. And just the fact that this conference is beyond sold out, I think is really encouraging in terms of the level of interest in this community. From where I sit, meth has definitely hit Santa Cruz. There's no question about that. But it's shown up in treatment a little bit more slowly than it has in other parts of California and the nation. I'm not sure if it's good news or bad news, but meth is only in the last couple years replacing heroin as the drug of choice among our treatment clients. And this is most particularly true in our more intensive forms of treatment, such as residential and day treatment. In listening to the whole discussion and more that we'll hear, I think one of the reasons that meth is attracting so much attention is because of the way people behave when they're high. And our last big epidemic was heroin, and if you have a heroin addict, when they're high, they're generally pretty mellow, unless they're in withdrawal and desperate to get their drug. It's not at all the case with methamphetamine, so it really brings those people to the attention of law enforcement, to the attention of child welfare services in the ER, as you just heard. So it becomes a much more demanding kind of drug to deal with. I was looking at some of the local statistics because I know there's national variations in how meth is used and who uses it. Just to give you a very brief rundown, consistent with what Dr. Rawson was saying, more than half of our admissions for meth are women. We're not finding much in the way of variation in terms of use by different ethnic groups. We're finding that fewer youth are using meth than in the young adult and older adult population. Though this may be an artifact of the statistics because almost all of our adolescent admissions are to outpatient services rather than residential, where you see higher proportions of meth use. Smoking is the most common route of administration. It's about 71%, followed by inhalation and injection at 13%. So we do have a lot of the folks who are presenting greater degrees of problems, but not the most problematic as among the injection users. So that's a little bit about prevalence. In terms of responses to the problem, I want to talk a little about the treatment response and also the prevention response. With respect to treatment, yes, it is available in Santa Cruz County, and we have specialized programs for youth, adults, women, Latinos, people in the criminal justice system. That's the good news. The bad news is that just like every other county in California, the demand for treatment far outweighs the availability of treatment. When we take national statistics on drug abuse prevalence and cast them against the Santa Cruz population, we've got about 20,000 people in any given year, and this is in a county with a population of 260,000. We have about 20,000 people who need treatment. We've only got about 3,000 people in treatment every year. So we're reaching about 15% of the population who need it. So what do we do with respect to meth? Number one, we look for new treatment resources, and we're out there beating the bushes with grants, with Medi-Cal, with everything we can find every year. We've got some interesting new developments in working with the child welfare system, particularly trying to catch women and families before they get a formal CPS case opened. But with the lack of new resources, there's still a lot we can do in terms of adjusting our existing programs to address the unique needs of meth users. a lot of the issues that Dr. Rawson mentioned around cognitive functioning, memory deficits, impulse control, sexuality, judgment, and so on. We've done a fair amount of training in Santa Cruz and have some more lined up to work with our treatment providers to try to adjust programs. I'm getting the look from Freddie, so maybe I'll cut this short. I was the only one that wasn't at the pre-meeting.
You see?
So I'm kind of winging it here. Just before I move on to prevention, I did look at some of our outcome statistics for meth users in treatment, and in terms of folks completing treatment, meth users are doing just about as well as everybody else. And also, when we looked at our Prop 36 clients, these are folks who are getting treatment instead of jail under Prop 36. We looked at rearrest rates 2 years post-admission, and the meth users were not doing any better or worse than the general population. So, yeah, meth treatment does work, and that we can demonstrate that on the local level. In prevention, most of our prevention is focused on youth development rather than being specific to a given drug. So we're trying to help kids learn the skills that they need to be successful adults, pair them with positive adult mentors and positive peer relationships. Having said that, education is a piece of that overall approach, and we're doing a number of projects specific to education around meth. I won't go into the detail on that right now, but so the bottom line really is we're an underfunded treatment system. We've got to get more resources for treatment. Having said that, we can adjust and redesign and retool the resources we've got to be more effective. With respect to prevention, working with the entire community, and that's the folks in this room, plus to address the problem from an education perspective. So thank you.
Thank you. Next on our panel is Dr. David Lowe. Dr. Lowe is the medical director for the County of Santa Cruz Mental Health and Substance Abuse Services. Dr. Lowe received his undergraduate degree from Washington University and his medical degree from the University of Illinois. After training in psychiatry at the University of California, San Francisco, Dr. Lowe worked in the Community Mental Clinic of San Francisco's Chinatown and North Beach areas. Dr. Lowe's interest in mental health aligned to areas of community mental health, post-traumatic stress disorder, and psychotherapy. David?
Well, it's an honor to be at this panel, to be talking about this very difficult problem we have. I just want to say a few words about what it's like day to day for community mental health for us with this problem of meth. I think it takes a toll on a number of levels. We certainly see the toll on the individual who struggles with meth. There's profound depression, as you've seen from Dr. Rawson's talk. There's lingering psychosis, and there's no good treatment from the psychiatric end. I see a number of our staff psychiatrists here. They can all attest to the effort, the repeated visits, and the many months that we put into helping somebody with depression or with paranoia. And there's no robust response to that. So given that there's no effective medical treatment with medications, it's, I'm forced to think about my training, which was on the biopsychosocial model. And it's great to see everyone here because I think it really does take a community. There has to be significant input from the social end, from political forces, legal forces, as well as further advances in the biology realm. And with, as the research shows, with the psychological realm, there's significant interventions, such as with the matrix model, with CBT, that can target this really difficult problem. Because it takes quite a toll, not just on the individual, on the staff. It confounds the diagnostic process. It confounds the treatment process. A lot of people are misdiagnosed with bipolar disorder, placed on inappropriate medications, perhaps. Certainly, it's almost impossible to differentiate between thought disorder and meth when somebody's in the throes of psychosis. So again, I want to say I really appreciate your presence here, and I hope that we can begin to take steps towards making a difference. Thank you.
Thank you. So our next panel member to give us the perspective from the law enforcement here in Santa Cruz is Lieutenant Escalante. Lieutenant Rudy Escalante has been with the Santa Cruz Police Department for nearly 21 years. He is a Santa Cruz native. He has developed court-recognized expertise in the field of narcotic recognition, identification, investigation, as well as gang identification and investigation. Lieutenant Escalante is the evening watch commander and has downtown Santa Cruz in his area of responsibility. Lieutenant Escalante has a Bachelor's of Science degree in Business Management and is currently enrolled at San Jose State University as a graduate student in Public Administration. For the past 3 years, he has been the president of the board of directors for Janus's drug and alcohol treatment program here in Santa Cruz. Lieutenant Escalante.
With all these doctors up here, I wonder if somebody's got a spare degree for me or something. But, fall for some medical condition, I'll be in good shape. You know, how methamphetamine impacts us as an agency is tremendous right now. And I'm glad the fact that with all these doctors up here, it brings up a point, the fact that we have these medical experts and experts in psychiatry up here, and we're talking about people who are under the influence of a controlled substance that increases their paranoia level. And then we're asked as law enforcement officers without the expertise in the medical field or the psychological field to have to deal with somebody in a difficult situation as it is typically going on. So we're taxed to a point where we have to send anywhere from 4 to 6 officers in these violent situations that come up to try and appropriately deal with it. From that aspect, we're also trying to figure out, is this a case where it is strictly a mental health issue or is it a drug issue? And then some point in time during that conversation is when it could possibly turn nasty and ugly. And it becomes a really scary situation for us. And then with the officer being potentially injured or the public perceiving what is actually going on when it's really not, we end up with an injured officer who's now on a workman's comp issue for several months. What we also experience problems with methamphetamine is from a hazardous material issue. Within the last year, we had a patrol officer discover a meth lab inside a vehicle that was parked at a shopping center. It was a abandoned vehicle, and the people inside were living in it and were basically cooking their methamphetamine out of there. Now the problem with that is that you have people who are disposing these chemicals right out into the public street where people are walking, and that creates an issue for us. It is so easy to produce methamphetamine that people can actually just do it in the trunks of their cars. The vehicle could be parked right in a motel room or a motel complex, and the suspects or the individuals involved would be in their motel room, and they're just actually involved in a cooking process in a short period of time. So we deal with that issue. What we've seen over the last 5 years in the city of Santa Cruz is every year we've had about a 5 to 7% increase in calls for service. Now, I cannot say that they're directly related specifically to methamphetamine, but it correlates with the time frame that we've been starting to see a problem with methamphetamine. Now, we have a problem with an increase of property crimes, which is petty theft crimes, vandalisms, or break-ins, people stealing personal property. They use that material that they're stealing to support their habit. You'll see a lot of information in the newspapers lately where there's been a lot of bank robberies. People involved in those crimes are more than likely involved in methamphetamine use. They're using it to support their habit. The frequency will increase as their habit gets worse. They get more daring. They become more violent. They're willing to take the risks. They don't have the judgment skills necessary to decide whether what they're doing is right or wrong. Should they or should they not? Or do they want to involve innocent civilians who are out in the street? Those are the conflicts and the problems that we are having with the methamphetamine in our issue.
Thank you. Our next panel member is Dr. Max Camarillo. Dr. Camarillo is currently the Director of Counseling and Psychological Services at the University of California at Santa Cruz. He has been affiliated with UC Santa Cruz for over 25 years and is also on the staff of the Psychiatry Psychology Service at Dominican Hospital. His undergraduate degree is from UCLA in sociology, and his graduate degree include an MSW from UC Berkeley and a PhD with clinical emphasis from the Fielding Graduate University in Santa Barbara. His areas of expertise include the psychological service delivery in a university setting, as well as an individual treatment of anxiety, stress-related disorders, and trauma. Dr. Camarillo also has expertise in multicultural approaches to psychotherapy and organizational development. He also maintains a private practice here in Santa Cruz. And last but not least is Dr. Camarillo.
Thank you, Dr. Weinstein. It's an honor to be here among these esteemed panelists. And like Bill, I see a lot of familiar faces, UCSC colleagues, private practice colleagues, even colleagues from my former life in community mental health. And that goes way back. I'm glad to say that at UCSC we have very few problems. Students are really emotionally we don't admit students that have emotional problems. That's why we're doing so great up there. I wish that were true. And it's not just UCSC that's increasingly seeing students that are very distressed, students that are also abusing. It's a nationwide problem. I'm going to quote from a book that was written by a Harvard educator, Richard Rawson, wrote a book titled College of the Overwhelmed. And this is talking about national figures and data. And he starts out by saying that there's been a 900% increase in the production of methylphenidate, otherwise known as Ritalin, from 1990 to 2000. And that's juxtaposed with about 3 to 7% of school-age kids that are diagnosed with ADHD. There's been about a 50% of that 3 to 7 end up in college. So we're increasingly seeing students that are coming into college with that diagnosis. He quotes 16% of college students are recreationally using stimulants by mouth, snorting, or injection. 70% of them are men, 11% of them are women. Let me now move over to UCSC and talk a little bit about what we're seeing on campus. First of all, Counseling Psychological Services sees about 10% of the student body, and most of you, I think a lot of you know that we've got about 15,000 students on campus now, 14,000 undergrads, approximately 1,000, a little more grad students. And the primary presenting issues, as you could well imagine, are anxiety, depression, stress-related disorders, and increasingly some eating disorders. So, not surprisingly, given this increase in Ritalin that's floating around, what we're seeing is a lot of recreational use of Ritalin on campus. We don't have exact figures. About 3% of the students that use our service are presenting with a primary presenting problem of substance abuse. What effects do substance abuse, Ritalin, other substances have on the traditional college-age student? I'm talking about 18-year-olds to 22. Well, that's a time when the mind and the brain is rapidly developing. The effects it has, at the very least, can be disruptive, and at the very worst, can really shatter the lives of those students and the lives of their families. Students that are also abusing, have effects on the community. Oftentimes, their disruptive and violent behavior comes to the attention of law enforcement, and some of those students that are also abusing find their way into the behavioral health unit with a presentation of psychosis. So there's just a whole range of effects that substance abuse have on university students that is really pejorative. And so what can we do as health professionals? Well, what we're doing here, and it's great to see such a large gathering. We need to be more informed. And as we're more informed, we're in a better position to educate those those consumers that use our services. And so, thank you for coming out today.
Thank So during the break, we collected various questions from you guys, and we'll use that to sort of guide the remainder of the presentation here. Some of the questions are addressed to specific individual panel members and others to any and all that wanted to try to answer it. I guess if there are additional burning questions that come up as we answer these questions, if they can be somehow written down and brought up here, we can try to add those to the list. But in an audience this size, it's hard to have a lot of direct interactive stuff. But as much as we can, we'd like to entertain any additional questions that come up during this topic. The first question here is actually to Dr. Rawson. And the question is, how does the use of marijuana impact the brain recovery process of a chronic meth user in their first year of recovery? If there's any voice left, you can.
Yes. We don't, from a brain chemistry point of view, we don't have any information on that, although we do know that if you complete treatment and you continue to use marijuana, your chances of relapsing to methamphetamine are 3 times higher than if you don't use marijuana. But we don't have any information directly on brain chemistry recovery. But we do know marijuana is not helpful for promoting long-term abstinence from methamphetamine.
And certainly if other panel members have thoughts on that, feel free to chime in. Our next question is, do you feel that the 3-year mandatory incarceration of prenatal meth users might discourage prenatal youth care? And this was directed towards any and all. But perhaps Lieutenant Escalante?
I don't think so. I think treatment is still going to be the ultimate goal, and it's actually going to solve the problem sooner. People get to pass the message along, so I think it's better that they get people more involved in some sort of, whether it's court-mandated or self-admitted type of treatment, that is probably going to be the better way to go.
Okay. This one is for any and all panel members. It asks strategies for parents to detect, address, or confront suspected problems with meth abuse in their own children. Good luck, yeah.
Well, just as an anecdotal issue, I thank everyone for allowing me to be on this panel because I have learned a few things, but as I was exploring the internet, I found that there are drug kits that you can get for your children, and they're on sale right now, normally $30, and you can get them for $14.99. And they give you tips on how to discuss this with your child, and I was rather mind-boggling to me to see this site. But the testimonials were wonderful, of course. I think, once again, and having children that are currently of college and high school age, I think, once again, talking with them, we tend to be the best model for how they're going to turn out and giving them a chance to at least discuss it. But I think majority of the psychologists and psychiatrists are probably much more well-equipped than myself to talk about that.
I can share some anecdotes and maybe some ideas. Certainly, if you see any mood swings, that enters into the question, as well as other psychiatric diagnoses. And one thing that I came across when I first came to San Francisco, I came from Chicago, and as you saw from the map, there's not a whole lot of meth in Chicago, especially when I was in med school. I didn't know very much about meth, and when I first entered as an intern in San Francisco General Hospital in the ER, I learned about meth in a really interesting way, and it helps with diagnosis, actually. I tend to have a loud speaking voice, and it tends to be louder at nighttime when I'm on call. There's a particular subset of patients who present with psychotic symptoms who really did not like my loud voice. They would just shrink away from it, become more psychotic, and I learned a lot from the nursing staff around me. They said, that person's probably on meth because they're extremely hypersensitive to stimuli. I think that was in one of Dr. Rawson's slides. So that's not exactly a diagnostic test, but I think you can notice if somebody's really sensitive to noise, other stimuli as they're, both in the intoxicated state and certainly as they're coming off in that acute period. It's one thing to look at.
I'll take a stab at this also. And we are doing some training for specialized groups, high-risk groups such as parents of teens who have been suspended from school or truant. And looking for generalized changes in behavior, so changes in who they hang out with, if they get a whole new circle of friends and they look a little shady, grades falling, being secretive, heightened family conflict, and then all of the symptoms of meth use that we've just been presented with. All of those things can be signs, and I think the most powerful thing is to intervene before that, in the sense of what do you need to do to have a good relationship with your teenager and your pre-teenager in terms of creating an environment where they feel safe talking to you, where you can talk with them about drugs before they get to the age where you may be suspecting that they're already using. So you really need to move in sooner than that as a parent.
Well, this is probably more related to school-age children, but it also affects college students, and as you can well imagine, the last thing a college student wants is for a parent to know about anything that they're doing. But clearly, if there's a radical change in behavior and it's related to substance use and other psychosocial problems, we oftentimes really encourage the student to give us consent to talk with parents. The more they can mobilize their support system to get into recovery, I mean that's critical. Yeah, I guess that's about it.
I can sort of comment from my end of the world, working on the inpatient psychiatric unit, that unfortunately, by the time an adolescent or a young adult comes to our unit in a grossly psychotic state and combative and brought in by police or referred by UC Santa Cruz, the cat's out of the bag in terms of the substance abuse problems once the tox screen comes back positive for amphetamines. And I see parents from all areas of awareness, some that were totally caught off guard by this, others that sort of saw it happening but chose to ignore it, and that others that were aware of it happening and trying to make an intervention, but unsuccessful. So I can't overemphasize the importance of education, of communication, and just being aware of your children and their behavior, changes in their behavior, changes in their peer group. All these things are out there for people to see if they only look for them and talk about it. But it's a tough question to try to address. Our next question is, let's see, it was directed to Dr. Manov. What treatment resources need to be enhanced for meeting treatment here in Santa Cruz County? How can we do, what can we do to raise awareness, educate community members? And then also a good question, what would this cost and how do we fund this?
That was about 5 questions at once. How much time have we got? In terms of changing treatment, I touched briefly in my prepared remarks around some things that we need to do to change treatment to make it more specific to the needs of meth users. Particularly cognitive behavioral treatments to help manage impulse control and help increase planning ability, and these other kinds of things that are impaired. Dr. Rawson touched on client education to help prepare them for the extended period of adjustment in their brain chemistry. Using visual and metaphoric mediums for treatment because some of the linguistic abilities, cognitive abilities are impaired somewhat. I mean, there's a number of ways you can adjust existing treatment. One of the challenges that is most difficult is one of the ways that we have dealt with the lack of adequate funding for treatment is that we have limited length of stay in residential programs that we fund. And this is contraindicated in terms of how long it takes the brain chemistry to adjust. So one of the solutions that we have attempted is, okay, we can only afford 2 months of residential treatment, but we can put someone in a sober living environment coupled with outpatient and step them down to a lower level of care when they're stable. Now, if we had enough money, yeah, it would probably be preferable to keep them in long-term residential treatment. So we can mitigate the impact of inadequate funding to some degree, but I wouldn't tell you that we've got it fixed. That's going to take money. A survey of counties relative to Prop 36 funding, which is one of our larger funding sources, they estimated they'd need about an extra 25% of dollars to adequately treat the people. We haven't really done those projections because, to be honest, it's kind of a waste of time. I mean, we can say we need this much more money, but we're better using our time chasing after grants, chasing after funding sources that are low-hanging fruit, if you will. I forgot the other parts of the question.
You touched upon some of them, perhaps addressing if there were particular things that could be done to enhance treatment specifically here in Santa Cruz.
Mm-hmm. Okay. So I think the ability to extend length of stay, as I said, some of the changes in treatment. And there was also some discussions around questions about community awareness and education. And we've got a couple projects going. One of them is with the Together for Youth Prevention Coalition and the local Rotary Club. I don't know if they're represented here today, but they've taken an interest in this issue, and we're doing some planning around a broader scale community awareness campaign relative to meth. I think it's pretty clear that most people know that meth is pretty bad for you. I don't think that's an issue in terms of community awareness. What I think we really need to focus on is targeted education for youth and parents at highest risk of developing a meth problem, or even more generically a drug or alcohol problem, because they're all tied together in terms of risk factors and protective factors. So I think targeted prevention, because we don't have enough money to give an intensive prevention curriculum to everybody, I think is the way to go.
Just a general question, Bill. How many treatment beds availability, what do we have in the county?
Okay. Well, that was part of the talk that I didn't have time to get to, so I have it right here. In terms of publicly funded treatment beds, we've got 65 publicly funded treatment beds, 14 day treatment slots, 80 methadone slots, which of course are for opiate users and not meth users, and approximately 10 outpatient counselors, 10 full-time counselors. And that's for about 20,000 people a year needing treatment. We serve about 3,000 a year. So I can't emphasize enough how underfunded the system is, and I cannot imagine a person showing up at an emergency room having a heart attack and being turned away because there is not enough resources for medical care. Yet that happens every day with respect to people who have drug problems. And I think that's a societal, political, national problem.
Thank you. There have been a couple of 3 questions sort of trying to touch upon the connection between the treatment of attention deficit disorder in children with Ritalin and then subsequent abuse of methamphetamines as adolescents and adults. Anyone want to tackle that one? Next question.
Go for it.
There was actually a blue ribbon panel about a year and a half ago that reviewed the literature on that, and their very strong recommendation was, with the proper diagnosis of ADHD, treated kids with those medications have a lower risk of developing substance abuse disorders than do untreated kids. The trick, though, is the diagnosis, that there's a belief, a perception that many kids who do not really meet ADHD criteria are treated with those medications, and that may be a problem, and that may actually worsen the situation. But for a kid who really has a good psychiatrist who's made a clear diagnosis of ADHD, you're far better off treating them with those medications and reducing their risk of later substance abuse than not treating them. But they have to be diagnosed correctly.
Thank you. Next question was directed towards Drs. Lowen and Lapid, a question about drug-drug interactions between methamphetamines and prescription drugs.
Methamphetamine, as far as interactions per se, as any stimulant, obviously if you're already on stimulants, etc., will compound that. It's a fairly open-ended question. Interestingly enough, in the treatment of methamphetamine issues, particularly seizures, benzodiazepines are really the drug of choice for that, as opposed to Dilantin. And so there are some drug interactions which are less or there are some drug interactions from the standpoint of how to treat these patients in the emergency department, particularly for seizures. The benzos are the more appropriate drug. For hypertension, one of the issues that we commonly will give, or one of the drugs we commonly give people, are beta blockers. This can escalate the hypertensive crisis, particularly with someone on methamphetamine, because it blocks the beta effect and only allows the alpha effect, which will then increase the blood pressure. So one of the things that we routinely use for elevated blood pressure, we cannot use in a true meth overdose or a methamphetamine hypertensive crisis. So you do need to be aware of that. And one of the things that we found too, or one of the things in some of the discussions we've been seeing, we talk about this as a population base of young adults, etc. What we're finding, and I think one of the things, particularly from the emergency medicine standpoint, is that we need to start considering and particularly asking older people, my age people, are you using methamphetamine? You'd be surprised at the number of people that, well, they may or may not answer yes, but will test positive for that. And what we're seeing, and I think what we are going to see in the future, as Dr. Rawson mentioned too, the medical effects. We deal a lot with the acute psychotic effects and those sort of dual diagnosis things. I think the medical population, particularly for acute coronary syndrome, for cardiac disease, for strokes and that type of thing, are going to be increased in the population that uses these drugs. So we need to be aware of that, and I think address that a little better than what we have been currently.
In the psychiatric realm, I think the most obvious danger comes in when somebody does not tell you that they're taking meth, and so that already predisposes them to have seizures, and you prescribe something on top of that, like Wellbutrin, which can add to the seizure risk, or any number of other psychiatric medications that can add to the seizure risk, lowering of the seizure threshold. But that's, I think that's less a day-to-day event than the individual who comes in looking for Ritalin or a stimulant to treat their ADHD symptoms. They may be psychotic already due to maybe a primary psychotic disorder or a methamphetamine-induced psychosis, or both. then that really confounds the picture, and that really puts you in a diagnostic and treatment dilemma. Luckily, it's pretty clear that stimulants will produce psychosis, and so we absolutely do not go that route when somebody is acutely psychotic. But let's say they become less psychotic a few weeks later, and they're still asking for the stimulant for their ADHD. You know they've been psychotic, and you still don't quite know whether they have schizophrenia or meth abuse or both. So as you can see, it's intricate and it's complex. You have to be very careful with what you prescribe, both for the medical reasons that Dr. Lapid has brought on, but also to try to obtain some clarity and some response in this complex person.
Yes, sir.
From our perspective, from a law enforcement perspective, the issue that we deal with, which they just highlighted as well, is as a first responder, we don't know if it's a prescription medication or if it's a methamphetamine issue, or both. So trying to make that determination in a situation, especially with family members around, or in the middle of a street while a person is having a seizure, trying to make that determination is extremely difficult. What we're seeing also is people are selling their prescription medications to help support their habit, and then the reason why they're taking the medication is not being treated, so that increases their risk to having to deal in a situation that we're confronted with.
And one of the other issues too, the majority of the patients that come in with positive drug screens, generally it's not just for one drug. Routinely a urine test will test for 6 or 7 different classes, and every once in a while you hit the jackpot and get positive on all 6, but there usually are more than one substance involved, so that will certainly cause with some interaction.
And I can certainly sort of echo that from my work as well, in that there's not only the drug-drug interactions, and then there's the drug diagnosis interaction, and trying to determine which is what. It's sort of a chicken and the egg type of problem sometimes, because as had been alluded to earlier, someone under the influence of amphetamines can look identical to somebody in a manic state with bipolar disorder, or even at times a schizophrenic. And so it's very tough to tease things out and make a clear diagnosis, and tox screens are helpful, history is helpful, but sometimes it's just really tough to determine the difference. So there's a lot of muddying of the waters that takes place when you add amphetamines into the mix. Our next question is for Lieutenant Escalante. How do law enforcement officers determine whether to press charges or bring an individual to the hospital?
A lot of it depends on the crime. If it's a misdemeanor that's not committed in the officer's presence, we would have to have somebody indicate that they want to have this person arrested, and at which point we would accept that citizen's arrest. If it's a felony type situation, then we would go ahead and book him as such. We can have some flexibility where we can call a judge and probably cite a person out if we know they're going to be in a hospital setting for a period of time, or depending again what the crime is. So we have some latitude in that, but for the most part we're kind of bound by what the crime is itself, and we try and make a determination from there. And a lot of it has to do too with the age of the person. If they're under age 18, which that happens frequently, is it a situation we can cite and release to the adult, or is it if we can get hold of the parent, or is it something that we're going to need to take them to a juvenile detention facility?
Terry, do you dare comment on that piece?
I'm going to get in trouble on this one. I think one of the things that we've seen is that drug court certainly does help in getting people into treatment. And I'm really not a Republican, but I think as I'm getting older here, I'm looking at more and more from the legal standpoint. So I think getting them at least into the system, citing them, etc. I realize that's when you start getting into other socioeconomic aspects of now flooding the courts, flooding jails, flooding juvenile hall, etc. But when I sit on a panel here, as opposed to when I'm in the pit, when a juvenile is brought in and then is released to the parent, it gets my dander up a little bit in that I feel like there may be an opportunity lost for helping that individual.
And, sort of one of the themes is sort of, yes. We love our law enforcement, but there's, as you can sort of imagine, a bit of a turf battle that sort of takes place when police come in contact with someone who's suspected under the influence of amphetamines and may or may not have committed a crime that may or may not be a felony, that may or may not be worth pressing charges on, and that may or may not end up either on my doorstep or Terry's doorstep. I guess the theme is that it puts a burden on both law enforcement and the treatment system. It takes up, the time of physicians. It takes up an ER bed. It takes up a behavioral health unit bed. There's a lot of violence associated with it, a lot of staff injury, both for medical personnel as well as law enforcement. And so I know this has been drilled home a few times, but it's obviously a big issue for all involved, and exactly how and where to treat is still a bit of a problem.
I'd like to comment on that also. I mean, as long as the person is not violent and not predatory in some way and not so medically unstable that they need medical attention, we'd much rather see them in treatment than in jail. And the statistics, thank you, the statistics from Hayward in terms of drug court, we have a similar experience here with our drug court in that it's very hard to get addicts to sit still, especially during the first couple months. And the threat of jail, in addition to the support of treatment, seems to be very effective in getting them to sit still long enough for them to get a few clean and sober days under their belt, and also to start getting it in terms of treatment. And so we have entered into a number of partnerships with the criminal justice system, whether it's through drug court or Proposition 36, work that we've done on the juvenile side, to try to use the coercive power of the criminal justice system and the persuasive power of the treatment system to really make them work together. And that's a lot harder than it sounds sometimes, but if it's done right, it's, I think, tremendously effective.
Sort of a follow-up question to that, and has to do with how exactly does court-mandated treatment work? Certainly it's a question I get asked by parents out of frustration of what to do. You've identified this as being a problem in your child, and yet there's no way to get them into treatment. Anyone be able to answer that, and how specifically does court-mandated treatment work?
Well, let me take a shot at that one. There are various systems set up, and they're in various stages of completeness for folks who are in various stages of involvement with the criminal justice system. I think we've got the best developed systems for folks who are most deeply penetrating into the criminal justice system. Of course, their severity of their crimes in the sense of violence and predation notwithstanding, and people do need to be held accountable for their behavior, don't get me wrong on that. But having said that, our adult drug court, for example, these are folks, and it's per the terms of our grant, are felons. Many of them, almost all of them, have multiple prior arrests for drug use. So they're very involved in their addiction, and they're very involved in the criminal justice system, though they're just shy of being headed to state prison as a result of the non-drug aspects of their crime. These folks are, it's a phased year-long program, so intensive outpatient 3 times a week plus 12-step meetings, appearing before the judge weekly, being tested 3 times a week. And then as they progress in treatment, the intensity of treatment, court appearances, and drug testing gradually declines. We have a treatment team consisting of the judge, treatment provider, probation, oftentimes public defender and DA will be present. And we coordinate, how's this person doing? What's the appropriate response? So when that person shows up in court, it's not the usual adversarial free-for-all, if you will, in terms of what's the criminal issue and how can you either nail them or get them off. It's really more a coordinated response in terms of, well, what does this person most need to help them succeed and stay clean and sober? So it's a very different relationship amongst the criminal justice partners, and also a different relationship between treatment and criminal justice. We're not hiding the ball from them. That's what Judge Kelly keeps telling me. and they're not. They also have confidence in our treatment recommendations. So it's a much more powerful kind of arrangement in terms of, because it's just like a kid with parents who don't get along. If you can play the two off against each other, you can do anything you want. And it's the same kind of thing in drug court.
Bill, I would echo that. I think one of the things that we've seen in our community over the last few years is a much greater integration between law enforcement, between treatment programs, between, we have a few initiatives between the Homeless Health Persons Project as far as for alcohol abuse, drug abuse. It is now on the radar, and people are now seeing this and are seeing the effects of getting social services involved with these people and keeping them out of the emergency department or keeping them out of whatever problem they may be in and getting them, back sort of in the mainstream. And although it's incredibly labor intensive on the first part of it, we are starting to see some of the effects of that. So I echo those trying to keep it going, basically. So.
Okay. Looks like our next question comes from a prospective home buyer. How long do the cooking toxins in a home linger after all chemicals have been removed? Is a home ever livable again? And what type of cleanup must be done to make a place habitable after a lab has been discovered and removed?
Well, that's for me, I can tell. It is an extremely dangerous situation. The reason being is because of the chemicals as such, that as people walk through them, children crawl through them and they get them on their hands, you just can't clean the carpet from it. It has to all be taken out. The chemicals can be extremely toxic to the point where they'll burn through the flooring. Depending on what type of chemicals that they're mixing, what the environment is like, they become explosive. The ground becomes contaminated. It is basically a hazardous material spill that we have to call in the professionals who do deal with those types of spills to adequately deal with it. The lab teams that come down from San Jose and our local narcotic enforcement agents have to dress up in respirators to go deal with these spills with these labs. They have to take special precautions as far as the footwear and the clothing that they're wearing. It's all disposable lab equipment that they have to wear in order to properly deal with them. It can be upwards of a 48-hour process just to break them down before the hazardous material teams can go in there and deal with all the chemicals. The site is almost just a waste, depending on the size. And Dr. Rawson talked earlier about these super labs. They are extremely out of urban areas because of the smell, the odors, and the problems that are associated with them. Unfortunately, the cartels are starting to use these rural areas with cover of trees and using water systems to try and help cook with the cooking process. So they're contaminating rivers and streams. So it's a really serious problem.
Next question is for Dr. Camarillo. What is the university doing in the areas of education, prevention, and treatment related to student methamphetamine abuse?
Well, education and prevention is currently being done through the University Health Service. They have a health promotion and prevention program that's pretty active on campus. In terms of treatment, we really don't offer any treatment on campus. If a student, it needs, more intensive treatment, that gets referred off campus. Could be residential treatment or intensive outpatient. We just are not, we don't have the kind of staffing and expertise to treat substance use problems on campus per se.
Thank you. Dr. Lowe, where can I send a young 25-year-old male who is a methamphetamine abuser and possibly diagnosed with bipolar disorder but needs treatment?
Where's Alicia? Well, we have walk-in services available at MLI, or you can call ahead for an appointment. And Alicia's team, and working in conjunction with the doctors, will interview the individual, and we'll try to tease out as best we can through the presentation and through history gathering what the diagnosis is. That may take a considerable amount of time, depending on how symptomatic somebody is. I mean, the easiest way to tell somebody the easiest way to diagnose bipolar disorder is to actually witness the manic episode. And if you've seen the classic manic episode in one person, that's pretty, it's pretty memorable, and it's easily distinguishable from, in my opinion, distinguishable from a meth-induced manic episode. At least I think in the classic picture, that is, but most people do not fall in the classic picture. So certainly county mental health services were available for schedule or walk-in assessments of that.
Thank you.
Thanks for not saying the ER.
The next question is directed towards Drs. Camarillo and Rawson. I am a recovering meth addict. I have experienced severe memory problems, including the ability to recall words and retain new information. Can time help heal this problem? And secondly, what additional effects may I experience from further aging, i.e., will it get worse?
That's interesting. That's the memory work on words, word memory. We've done a lot of cognitive testing, and word memory is the one that takes the longest to recover. You actually get your memory back for things like numbers and pictures and music, things like that, much more quickly. Word memory, for some reason, is more delayed. It's actually also, just as a side comment, when we look at it with kids who are prenatally exposed, if you look at 3-year-olds, they have a deficit in their word functioning. So it's something about the part of the brain that controls word memory that is affected by methamphetamine. Specific timetables have not been worked out or determined. It looks like the majority of recovery for word memory occurs within the first 12 to 18 months. It can take that long. After that, there are exercises people can do to improve their memory for words, but in terms of the biological recovery, it's probably going to be completed pretty much by 18 months or so. So if you're beyond that, you may want to get some, at certain learning, vocational kind of training. You can actually improve that with certain exercises, but it's interesting you mentioned words, because that's the one that takes the longest. And your perception is absolutely right. That's the, and when you think about treatment, what is treatment is words. It's changing words, which is one of the reasons why methamphetamine users need extra assistance in remembering things. We're trying to do more treatment in pictures and videotapes and coming at it from a different direction, because word memory really is uniquely delayed or damaged by methamphetamine.
Yeah, I don't have a whole lot to add to that. I guess the good thing is that even the addiction has not there's not permanent irreversible damage, and the brain has an amazing capacity to regenerate and to heal itself. I was thinking neuropsychological testing if you were really concerned, but it sounds like it's just a matter of time, and you can save yourself several $100s and not do the testing, because it does sound like it's a matter of time.
Interesting question here for Dr. Lapid. Is a drug toxicology screen becoming routine in the emergency room? In other words, for people presenting as just your generic ER complaint?
No. Certainly not routine. Any patient that is brought in on a 5150, on a hold, or who's going to be going over to the behavioral health unit or have behavioral health intervention, through our protocols, we do have urine triage drug testing. I mean, obviously, the psychiatrists and the PES workers need to know, are there other contributing factors to the psychological aspect? But no, and as I say, that's one of the questions as to the prevalence of it. We are not, we don't do drug testing on everyone who walks in the door, so the incidence could be much higher.
Mm-hmm. And sort of a follow-up with that is, what is your favorite medication to give in somebody presenting with amphetamine-induced psychosis?
For the psychotic aspect, or for the, I'm going to look more as the disruptive aspect, Ativan is probably the safest as a benzodiazepine. Haldol can certainly be used, and unfortunately, with Dr. Rawson's comment of keeping them in a nice, quiet environment, most emergency departments aren't that, and physical and chemical restraints oftentimes need to be used, but Ativan is probably the safest drug to start with.
And I can certainly comment on, as far as on the inpatient psychiatric unit, there is no real drug of choice per se. A lot of it depends on the presenting symptoms. Certainly, if interventions can be used to avoid the use of medications, it is done. The use of seclusion rooms are sometimes needed, depending on how violent the individual is. Medications used range from Ativan, which is an anti-anxiety medication related to Valium, to actual antipsychotic medications that need to be given if indeed the person presents as a danger to themselves or others. So it really is situation dependent.
I mean, as an anecdote, I think it sort of depends on the staff's how the shift's been going. Also, having a disruptive, noisy, yelling patient, the tolerance for that.
Oh, it's the train.
It's
the train.
It's not. It's not an earthquake. It's not an earthquake.
For the,
Okay.
Yeah.
Well, we'll have some aerosolized Ativan coming very soon. I lost my train of thought.
no pun intended.
Oh, yelling patients. I mean, it's incredible how it's sort of this white noise aspect that, we hear the monitors, we hear the alarms, we hear this, and you realize, this person's been yelling and screaming and cursing, and then finally when you do give them the Haldol, and in all honesty, we try not to do that because number one, psychiatry cannot really evaluate them for any number of hours, which is now guaranteed that they'll be in our department for longer. But when you finally do that, after about 20 minutes, you realize your stress level has gone down incredibly, and it's, why didn't I think of this sooner? So it is sort of a push-pull aspect, but it takes its toll on you. So.
Thank you. This one, it looks like, would be for Rudy. In California, do the court systems vary in how they address ordering court-mandated treatment programs for meth offenders? In other words, in Northern California versus Southern California?
I've testified in various regions of California, and I definitely see a big difference. It's obvious in Santa Cruz County. There's a lot more support for drug treatment, I think, and we see the benefits from that from different angles. And it all depends, again, from jurisdiction to jurisdiction, how the court is going to deal with a individual regarding their history and what the crime is. Is there a victim involved? There are mandated laws and sentencing laws that need to be followed, but for the most part, Santa Cruz County is definitely much more successful in obtaining treatment for individuals, especially around methamphetamine.
Okay. The next question is for Dr. Manov. It appears to be asking that if a person who has had a history of methamphetamine abuse is now clean and sober, is it safe for them to use alcohol socially?
Never say never, okay? But I think the research is pretty clear that there's generalization across addictive behaviors, and that use of alcohol impairs your judgment, is going to increase the likelihood of a slip related to other drugs. And having said that, there are some people who can cease their primary drug of choice and continue to drink socially. And what's unfortunate is that every person who's addicted to meth thinks that they're that person. So in a treatment setting, generally speaking, abstinence is the prescription, and the notion that you can drink after being clean from meth or heroin or whatever is strongly discouraged. But it in fact does happen with some people. And I'd like to get Dr. Rawson's take on that too.
I agree with you completely.
Next question actually is sort of for each panel member to try to address. If they could name one thing that they can do within their scope of practice or daily activities to reduce the methamphetamine problem here in Santa Cruz, what would it be? Anyone want to go first?
Well, I'll say before Bill says it, if we had a direct pipeline between access and substance abuse treatment, that would be great. I mean, substance abuse and mental health are in the same building, yet we have such limited resources. We see somebody who's wanting treatment, wanting help for meth, and we'll have a wait list, or we'll have something very suboptimal to offer. So my wish list would be ready and easy to access treatment for them.
I think there are so many ways of addressing it, not only from intervening in a child's life and intervening or assisting family members who are single parents, to the criminal justice system of assisting people who are coming out of institutions who have not been treated, they've just been locked up. There's just so many variables. I'm not sure where to go. I think I would like to see some sort of mandated treatment, increase treatment facilities in our jails and institutions. They're just way too overcrowded. And the people that are coming out are worse than when they went in. So I would address that.
Okay, thank you.
I echo both panelists' comments. I mean, I think that the treatment aspect is really the key to this. And as Dr. Rawson mentioned, basically, we have a revolving door. We see a lot of the same people with the acute episodes, and knowing that when they are discharged, with their little instruction sheet of here, follow up. That doesn't happen. And having an ability, a mobile team, something that could come intervene at the time that they're there, because when they're there, that's when you at least have a hook into them, and once they walk out the door, they're lost again until they come back. So trying to improve that aspect of it.
Yeah, I would just add that, we can't continue to keep building more, state prisons. The penal system is not the answer, and treatment and prevention is.
I guess I get to wrap up on that question. Yeah, obviously we need more resources, and we're going to keep working for that. But that doesn't mean we have to wait until that shows up. And the things that we're doing in terms of adjusting, redesigning our existing treatment system to make them more appropriate for meth users, those are primarily training issues. There are also some program design issues that go beyond training that I think we can make progress. The other area where I think we can make progress that we're doing is working with our interagency partners more effectively. So, over the last couple of years, our interaction with Child Welfare Services, CPS, has just tremendously increased, and we've got a case manager at the detention hearing. That's the hearing where the court takes jurisdiction over the child, to intervene at that stage. That takes resources, but some of it you can do with creative use of the resources you've got. Likewise, it's not meth, but what we're doing with chronic public inebriates and coordinating that effort with the courts. We've been very effective in decreasing ambulance rides and ER admits, and hopefully you're actually seeing that in the ER, Terry. I don't know if you see it or not. We're seeing it in terms of when we cost out how much we saved in jail days and ambulance rides and ER visits. The program is more than paying for itself. So there are some smarter ways to use the resources we have, because we put so much at the deep end and picking up the pieces. And of course you have to pick up the pieces. You got a legal obligation and a moral obligation to pick up the pieces. But is there ways you can shift some of those resources to keep more people from falling into the river upstream rather than having to pull them out of the river downstream? So I would encourage us to do more of that as interagency partners.
A question was asked to describe some of the specialty programs here in the county, such as Janus or the camp up in Scotts Valley. Anyone want to handle the Janus part of it?
I'm not quite sure I know what the question means in the sense of specialty programs.
Those that would provide residential treatment.
Okay. Programs vary in terms of length of stay, vary in terms of treatment model. Janus has 2 residential programs. It's 28-day program for men and women. And then they also have the Mondanero Baskin Center, which is a specifically program for pregnant and parenting women, which is residential. And the length of stay ranges from 2 months to 6 months or more. The camp, the county doesn't buy any beds at the camp, but I'm familiar with them somewhat because we contract with them for outpatient treatment. And I saw Steve Stein in the audience here somewhere. He left, okay. And the camp has a variety of residential treatment options, driven partly by what the person needs and also partly by what insurance and private pay will pay for. And they do have a greater degree of psychiatric support, as I understand it, than Janus, which has some psychiatric consultation, but it's definitely not a medical model program. I think it's about as much as I can say because I'm not quite sure what the gist of the question was.
Okay. A question has been asked getting back to sort of the biological aspects of this, over time, is there no dopamine left in the system due to neuron death so that meth stops working?
No. I mean, I suppose it's possible, but you're talking about relative amounts, and even the extended long-term user, when he takes his first dose of methamphetamine after a period of abstinence, he'll feel it. He'll get a dopamine effect.
And a
It's
follow-up.
going away. I think.
A follow-up to that would, does the reduction in dopamine drive the meth abuser to use more and more methamphetamines?
Yes, it does. Yeah, they're trying to often alleviate the anhedonia by taking methamphetamine to make themselves feel better.
One question that we sort of have touched upon a bit, but there have been so many people asking it, it may be worth sort of elaborating a bit on it. But how do you differentiate between mental illness and methamphetamine-induced psychosis?
Dr. Weinstein, you want to tackle that one?
Well, actually, David answered, I think, some of that at least prior, and sort of as had been mentioned, it's very tough sometimes, if not impossible, and gathering information in terms of the history, the onset of symptoms. Generally, a mental illness will not present overnight, whereas an amphetamine-induced psychosis will. Looking at a family history of actual mental illness, and of course, observing the individual over time is really sometimes the only way to clear it out. If you are unable to get a toxicology screen or better information. And so making a clear diagnosis is often just, sort of a detective job, and then observing, treating the acute symptoms as they come up, but not being quick to label somebody as having bipolar disorder, and setting them on a lifetime of treatment, whereas you sort of missed the boat and it was an amphetamine-induced issue. I guess the other sort of thing that has kind of gotten brought up from time to time in our discussion today is the whole concept of dual diagnosis, meaning where there is a mental illness, such as bipolar disorder, superimposed with a chemical dependency. And they do sort of feed off each other, and makes the treatment and diagnosis, as discussed earlier, that much more difficult. But it's probably, at times, some of the toughest parts of our work.
The only thing that I could add to that is, and this is a very, very general statement, is that I think the individuals who are in the acute meth-induced psychosis or a mood disorder, the ones who actually present seeking treatment or seeking help are very uncomfortable and very dysphoric. And it's very ego-dystonic. That's a fancy word for it. It doesn't agree with them. So this is, again, very general. Somebody who is in an acute psychotic episode due to their schizophrenia, it may not be that ego-dystonic. It may not disagree with them. It may be their family member or their housemate who's dragging them in. They may not feel like there's anything wrong. So the level of discomfort and level of dysphoria, the level of agitation as a result that they have can be an indication of whether this is drug-induced or a psychiatric disorder.
A question for Dr. Rawson, if there's anything left there, sir, is it possible that the effects of cocaine on babies in the 80s have caused brain syndromes that these individuals are now self-medicating with methamphetamines as adults? You can sign your response.
I suppose it's possible, but I don't.
Let's see, for Lieutenant Escalante, could there be a minimal security detention program developed similar to the Farms Public Inebriate program developed here in our county?
I think that'd be a question that the county sheriff's department would have to be responsible for, who are responsible for the detention facilities in our county. I think we could definitely benefit by a program similar to the serial inebriacy program that you're talking about. We've seen tremendous benefits for us, at least within the city. So I would definitely champion some sort of cause that way.
And a question from a budding chemist. What are the ingredients in meth? or what website were you on, Terry?
Besides the Sudafed, you're dealing with acids and acetones and ammonia. And a lot of it depends on the chemists themselves and what it is exactly, what precursors and what chemicals they've been taught on how to use it. I don't know if you want to comment any further on that.
Yeah, the Sudafed is the main one. It's gone.
That was the danger behind a lot of the problems with the spills, is because of the acids that are used, especially in the extraction of the Sudafed.
And then another question, sir, is what specific data is available to support the theory that meth has increased criminal activities here in Santa Cruz County?
From our perspective, it's hard to really track that because there are specific crimes that we wouldn't be able to track that it's connected specifically to methamphetamine. But what we are finding is the more people that we come in contact, our seizure level of methamphetamine has increased dramatically over the last 5 years. That's usually how we gauge it. And because of Santa Cruz County, we're a little bit slower than behind Southern California and some of the Central Valley. So by the time it works its way here, it's been a continuous problem in other areas. And so once that change occurs within the using community, then we start to see the change. But the seizures are up dramatically.
A question for the panel in general is, since meth abuse creates such a dramatic and broad societal problems, why aren't there any televised commercials educating people to prevent use? And how do we get this to happen?
I think that dovetails into Dr. Rawson's comment that the government felt that there wasn't a problem. I think it's public education, and that once again getting it on the radar for that. And as I think everyone sitting in this room knows, health care and social services is pretty low on the government's budget. And I think the more that we can bring this to the forefront, the more that we can become instrumental in getting it out and making a change and being the squeaky wheel, that's the only way it's going to happen.
And my understanding is the state of California Department of Alcohol and Drug Programs is working on a public education media campaign. I think they were also caught behind the 8 ball, as were the feds on this issue.
I see some head nodding. Okay. Let's see. This is a question asking, perhaps Dr. Lowe or someone else may chime in, the feelings or opinions of the use of Wellbutrin to treat cravings, and then how do you then subsequently prevent the abuse of Wellbutrin?
I think, as Dr. Rawson pointed out, there is some evidence that Wellbutrin, it can be effective both to treat the crash after meth use and to treat the cravings. It's not real robust, though, just speaking from my own clinical practice. And if any of the staff psychiatrists out there would like to chime in, please do so. I don't see it as being real robust, and because it's certainly not going to produce the rise in dopamine that you see with meth. I don't know if you want to...
Yeah. No, there's really no abuse of it.
Dr. Rawson said there's no real abuse of it, except one particular formulation. Wellbutrin XL, which is in a capsule form, is very popular because you can break it up and snort it. So we're more prone to prescribing the tablet form than the capsule form.
And what's the effect of snorting the Wellbutrin?
Snorting the Wellbutrin, I mean, depending on how many capsules you break up and how much powder you get to snort, is very stimulant like cocaine or amphetamine-like. It's very popular in the jail, and Dave Pollack can probably attest to that.
We've been, I guess, focusing a lot of our comments on young adults, but a question was asked is, what's the scope of the methamphetamine abuse problem in school-age children?
We do have data. Every other year we go out to the schools and survey grades 7, 9, and 11, and we get about 25% of the school-age population in the county, and that includes the alternative schools and the court and community schools, so we get a pretty good sample. And the last survey we did in 2004, amongst 11th graders, 3% reported use of meth in the last 30 days. And that compared to the statewide average of 5% of 11th graders reporting meth in the last 30 days. And it's a little bit perplexing because on the treatment side, we're seeing an increase in meth-related emissions among kids, teenagers. And I think what's happening is that among the population of teens who uses drugs heavily, they're shifting towards meth. But there's relatively few of those, so they kind of get washed out in the overall school survey statistics.
A question was asked, directed towards Dr. Camarillo, regarding the use of amphetamines at UC Santa Cruz relating to cramming for exams, and how socially acceptable is amphetamine use there, maybe compared to the acceptability of using marijuana.
Well, I don't have any hard data. It's anecdotal, but everything is out there, and so the stressful periods for a student are predictable. They're around exams, and some students will experiment with more Ritalin than meth. That seems to be much more prevalent on campus. And it can have some dire consequences. During midterms is when some of the health professionals at the university are out there, and it's predictable. Midterms times, you see a lot of students that are coming in there with they've suppressed their immune systems. They're coming in, they're ill, they're not doing very well. But students are still going to experiment, and hopefully most of them will learn that there's no substitute for just trying to put in the time to really prepare as opposed to cramming. Let's see. That's about it.
Mm-hmm. Sort of a question was posed: how do you, or how does society reconcile the use of stimulants in certain areas, such as in the military, for helping on long bombing flights, with not using amphetamines, as a message to send to children? or I guess for that matter, long haul truck drivers, and other professions that use stimulants.
Yeah, I've had that one come to me more frequently from clients about why they don't have a problem with amphetamines. It's because the pilots flying long missions in Iraq were using it. That made it okay somehow. And so here it comes back again. There's very clear differentiation between use and abuse and dependence. And don't ask me to give up my cup of coffee. Okay. And some people can use occasionally, and they're okay, but most people can't.
I'd like to maybe take the last 10 or 15 minutes or so, just for each of our panel members, maybe to give a couple of minutes of sort of a closing comment or remark, and we'll excuse Dr. Rawson and maybe start with David.
Well, I think we raise more questions and raise more awareness than solutions. But I think it's encouraging to be able to at least raise awareness and questions. And I'm hopeful that both science and society will continue to strive for ways to treat. And